Today's webinar is about treatment options for DLBCL. And let me take a minute to introduce our speaker. Dr. Phillips earned his medical degree from Rush University, followed by residency in internal medicine at the John H. Stroger Jr. Hospital of Cook County in Chicago. His fellowship training in oncology hematology took place at the University Hospitals in Cleveland. Before joining City of Hope, he was a clinical associate professor at the University of Michigan. Leading clinical trials into new targeted therapies is a vital part of Dr. Phillips' work. He has published over 40 peer-reviewed studies and attracted dozens of research grants. I'll now turn the time over to him, and I will be sharing his slides.
Good afternoon, and thank you everyone for joining. Thank you for the kind introduction, and happy to be here today to discuss diffuse large B-cell lymphoma and some more recent changes in the clinical practice of how we manage and treat patients with large cell lymphoma. And just to start, we'll actually just give a brief overview of lymphoma, just to sort of table set things. And then we'll dive into a little bit more detail in large cell lymphoma with some of just the base level things that we discussed in the clinic visit and sort of how we approach a patient in frontline therapy. So we can go to the next slide, please. Here are my disclosures. Next slide, please. And so just the agenda as I mentioned. So we'll generally just go over an overview of lymphoma, again, just to give some background information. And then we'll talk about diffuse large B-cell lymphoma, which is our most common lymphoma within the US. Next slide, please. So, lymphoma is a very general term. Basically, it just describes a cancer of a cell within our body called lymphocytes. Lymphocytes are quite important to our immune system, and there's a reason why we're able to fight off bacterial and viral infections. I think the importance of lymphocytes can't be any more sort of stated than what we've all experienced in the last several years with the COVID pandemic, and then obviously with our seasonal battles with influenza. The cells that we try to stimulate and try to prime to fight off these viruses are lymphocytes. And so, again, with lymphocytes, we have B lymphocytes, like B as in boy, and then we have T lymphocytes, like T as in Tom. The B lymphocytes are the lymphocytes that generally generate and make antibodies. T lymphocytes, I generally like to describe them as the enforcers of the lymphocyte family, and they go from cell to cell and throughout the body, eliminating anything that may be irregular and outside of the norm. So when we get lymphoma, it can generally arise from one of these two different cells, and then we would generally refer to as a B-cell lymphoma or a T-cell lymphoma. Within the body, these are generally located within lymph nodes that we have throughout. There are lymph nodes behind the ear, in front of the ear, around the jaw, neck, chest, the armpits, the abdomen, the groin, and even lymph nodes behind the kneecaps and elbows. The spleen is also considered a lymphatic tissue, as are the tonsil. And in certain organs, such as the stomach, lung, and intestines, we have tissue which is of lymphoid origin. And so, again, when we talk about lymphoma can arise in any of these different parts of the body, and it will be generally considered to be quite normal because we expect that tissue to be present there. Next slide, please. Sorry, you can't really see this very clearly, but this just lists the incidence of non-Hodgkin's lymphoma. And from this, you see that lymphoma is the 5th or 6th most common cancer within the United States. If we add together Hodgkin's lymphoma and non-Hodgkin's lymphoma, it does bump it up just above and to make it the 5th most common cancer within the US. Next slide, please. So if we look, incidence rates had appeared to be climbing if we look from the 70s to the 90s, but I will say there's been more of a plateau lately. A lot of the risk factors that we think are associated with lymphoma, at least environmentally, we think there's some concern with pesticides and herbicides in some of these environments. incidence just because of the overall aging population of the United States. As we get older, unfortunately, it leaves more room for errors, which leads to more incidence of cancers. In some situations, defensive medicine has always been part of their issue of increasing sort of discovery of lymphoma. A lot of patients are being found when they go into the emergency room for a different sort of issue. They get a CAT scan, and the CAT scan will demonstrate some abnormal lymphatic tissue leading to a diagnosis. In some of these patients, they may or may not ever have been diagnosed if left to their own sort of devices and not necessarily brought to medical attention for some different reason. Overall, as you can see, there's a slightly higher increase, at least historically, in men versus women. But overall, this disease is thought to be generally asexual in the sense that the rates in men and women are thought to be about equal in the case of lymphoma. Next slide, please. So when we talk about symptoms, it's a bit of a wide spectrum. We'll get into a bit more detail with this a bit later, but for the most part, the easiest thing to think about is that you'll have abnormal enlarged lymph nodes. Some of these lymph nodes, if they occur deep enough within the abdomen, a patient will be unaware of it because, again, you can get a lymph node the size of almost a grapefruit or a watermelon without noticing it because there's quite a bit of room in our abdomens. Obviously, depending on where we are, our age, some people have more room than others. But the classic B symptoms that you typically read about, which are fevers, night sweats, weight loss, those actually occur in the minority of patients, and most patients will actually come to medical attention before the development of these so-called B symptoms. If the disease is left alone long enough, you will see the development of these symptoms because they are usually synonymous with more aggressive and progressive disease. But if you catch the disease earlier in its clinical course, where the disease burden is less, again, you're less likely to have these symptoms present. In some situations, we can find the lymphoma in your blood, so that'll sort of indicate itself on lab testing. Or in some situations, when your bone marrow is impacted, we can find abnormal labs, which would then lead to the diagnosis of lymphoma. But there is no lymphoma-specific lab test, so there's no PSA for lymphoma. And so there's no blood test that we can generally follow and routinely say yes or no with respect to the lymphoma. Next slide, please. So the diagnosis of lymphoma, it is generally based on a biopsy. So it's either an excisional biopsy where the lymph node is removed to the body, and then we make an evaluation that way. In some situations, we can make this type of diagnosis, what we call a needle biopsy. And so we'll use a needle to take a sample of the lymph node out. We generally prefer lymph node guided biopsies versus excisional biopsies, just because, again, obviously surgery does equate to more complications in some situations. And so if we can make a diagnosis by just sticking a needle within a lymph node, we'll do that. Again, since lymphoma is not a surgical cancer, so it's not a cancer that needs to be treated or cured with surgery. Again, we try to minimize as much as we can the intervention of a surgeon into the clinical practice and diagnostic workup of a patient with lymphoma if we can. There are some lymphomas where, unfortunately, we will sometimes have to have an excisional biopsy, but again, those are few or far between. Again, as I mentioned before, sometimes the cancer can be found in the peripheral blood, at which point we can make a diagnosis just from a blood test where we send it for a very specialized test that sort of uses a sort of barcode reader to determine if there are any sort of abnormal copies of lymphocytes noted in the blood. And if we do see these abnormal copies, we call this basically a clonal population, which basically means that there's one cell that's copied itself numerous times, and it's the reason behind the cancer. And so in that case, we can make it from a diagnosis just from taking a blood sample. But again, that is not usually the majority of the cases with patients with lymphoma. Next slide, please. So other testing we use, so we use a PET CT scan, which is basically a test where we give you a radio-labeled sugar. Because this sugar will go in the areas with high metabolic activity, which are like cancer, well, cancers are in areas such as that. We use that sugar, and then it goes to an area, then they will snap a picture about an hour or so later, and it will show up as darkened areas where this radio-labeled sort of sugar is basically taken up in abundance to help us find out where the cancer is. We can sometimes use chest X-rays, but that's only for a particular type of lymphoma. And then we use other things just to give sort of more of a prognostic sort of score. So when a patient asks, how will I do with this type of cancer? What is my expectation? Some of these other lab values can sort of give us an idea of how we would expect you to respond to frontline therapy and what kind of outcome we would generally expect. Next slide, please. So when we talk about staging, so the main important thing to think about with lymphoma, staging lymphoma is a little bit different from stage from other cancers. We do from stage 1 to 4, which is very similar to any other cancer. The more important agent is a very small part of how we prognosticate and expect the patient to do with lymphoma. So again, in most situations, whether you're stage 2, 3, or 4, we generally expect your outcomes to be very similar. And only in certain situations, which you be in a stage 1, with that generally sort of change how we approach the cancer and sort of what we think your long-term outcome would be. But for the most part, again, whether you're stage 2, 3, or 4, and even in some situations with stage 1, again, how we approach you and what we expect from the treatment will be basically the same. These additional letters that we use, A or B, A being no B symptoms, B being presence of B symptoms, X meaning that you have a collection of lymphatic tissue that's greater or equal to 10 centimeters, or S meaning splenic involvement, or E meaning that there's an organ involved without much lymphatic tissue. So in this situation, it's to say if your liver was involved with lymphoma, it would be a stage 1 or 2E. E, again, indicating that it's not a typical nodal area, such as spleen, tonsils, or lymph nodes. Next slide, please. So this just gives a visual representation of how we sort of make a determination of stage. So we use the diaphragm as a quasi Mason-Dixon line, so north-south. Anything above the one part of the diaphragm and below is considered to be either stage 1 or stage 2. Stage 1, as you can see from this diagram, is a very localized cancer without any sort of additional areas. So it is located just in generally one spot. So it could be in the armpit, as you see in this diagram. It could be in the neck. It could just be in the chest in one little small area. Stage 2 is any amount of lymphatic or disease involvement above the diaphragm without anything below. Stage 3 is disease above and below the diaphragm. Now, while this cartoon is very sort of symmetric with the difference between stage 2 and stage 3, you could very well have 40 to 30 to 40 different sites of disease involvement above the diaphragm and still be considered stage 2. And you can look very much like this cartoon drawn here, have 2 spots above, 1 spot below, and be a stage 3. So again, staging does not necessarily equal sort of disease burden when we deal with patients with lymphoma. And again, stage 4 basically indicates that you have a non-nodal organ, let's just say lung involvement, and you have a non-adjacent lymph node. So if you have a lymph node in the abdomen and your lung is involved, you're automatically at stage 4. If your bone marrow is involved, you're automatically at stage 4. Again, it does not equate disease burden. And in most situations, it does not necessarily change how we would approach you with the disease. As again, stage 4 with lymphoma is very different from stage 4 with, say, breast cancer, lung cancer. Next slide, please. So very easy, this is how we sort of will separate and lead to our discussion with large cell lymphoma. Again, with B-cell non-Hodgkin's lymphoma, we generally have 3 major categories. We have an indolent, which is another way for saying slow growing, intermediate, and then we have aggressive. For all intents and purposes, we'll focus on aggressive, which is a curable form of B-cell non-Hodgkin's lymphoma. Diffuse large B-cell lymphoma is the most common aggressive lymphoma. It is the most common lymphoma overall in the United States. And so moving forward, everything else will be in relation to diffuse large B-cell lymphoma. Next slide, please. So with diffuse large B-cell lymphoma, historically treatment is really mandated with a regimen called R-CHOP. This includes rituximab, cyclophosphamide or Cytoxan, hydroxydoxorubicin, or we also call it just adriamycin, Oncovin, which is other name is vincristine, and prednisone. In general, this has been the standard of care since 2002 when we had a study in elderly patients with large cell lymphoma that showed the addition of rituximab to the chemotherapy backbone of CHOP was curative and better than CHOP alone. So R-CHOP from that point has been the standard of care. Again, rituximab in this situation is a CD20 antibody, so it's not a chemotherapeutic agent. It is an antibody that will bind to the top of the cancer cell and induce some immune response. But more importantly, has been shown to make chemotherapy more effective in all sort of ways, shapes, or forms. So it has always been a part of most of our treatment for patients with lymphoma. So if you have a patient with early stage diffuse large B-cell lymphoma, say you have a stage 1 or stage 2, treatment is usually with R-CHOP times 3 or 4 cycles. Again, we have if we use 3 cycles, it's generally in conjunction with radiation, where we will radiate an area that is involved with the disease. If we do go to 4 cycles, data has shown that we can give you R-CHOP times 4. If you are in a complete remission, we can forego radiation. So in patients who may have cardiovascular risk factors or other risk factors where radiation is not acceptable, again, we can still cure you without giving you excessive chemo, again, and also without radiation. Now, when we move to more advanced stage disease, typically stage 3 or stage 4, again, R-CHOP times 6 cycles has normally been the standard of care. And when I say a cycle is generally 21 days. So if we go back to our sort of alphabet soup to the left, rituximab or tuximab is given on day 1. Cytoxin, hydroxydoxorubicin, and oncovin are also given on day 1. All these medications are given through an IV. Prednisone is then subsequently given on day 1 as well, but that is given days 1 through 5. But this is given by mouth. So you will take typically 2 50-milligram tablets of prednisone at home, days 1 through 5, and then you will generally have 16 days off of all treatment and 20 days off of all IV medication. On cycle, say day 22 of that cycle, meaning after the 21st day, you will start the next cycle of therapy. Thereafter, again, we will repeat that every 21 days. So again, in total, you're looking at 6 21-day cycles for patients with advanced stage disease, stage 3, stage 4. And again, if you have more limited stage disease, meaning stage 1 and stage 2, you'll again get 3 cycles plus radiation or 4 cycles of therapy. Now, more recently, we've had a new trial that has come out that's indicated that we have a new sort of standard of care in patients with large cell lymphoma with advanced stage disease. If we go to the next slide, this study was the Polarix trial. This was a study that compared R-CHOP, which we just discussed, with our polar R-CHIP. Polatuzumab is a drug antibody conjugate. It is a CD79B antibody that has a drug attached to it. The drug is monomethyl E. The more important thing is this drug functions very similarly to vincristine, but it's thought to be a more effective agent in that class of drugs. And so the comparison here was to suggest if we could replace vincristine with polatuzumab, if we would have better outcomes in patients with large cell lymphoma. So again, this randomized phase 3 study, meaning patients were randomized 1-to-1 to either get R-CHOP or polar R-CHIP, did read out in early 2021 and gave us an indication that it appeared to show that polar R-CHIP had an improved progression-free survival compared to R-CHOP, meaning that patients who received polar R-CHIP, their disease stayed away longer than those who had R-CHOP. To date, we are still waiting to see if this leads to a survival benefit. As of right now, there is no survival benefit between the two. And more importantly, it does appear that there is a subset of patients with diffuse large B-cell lymphoma that may benefit more from treatment with polar R-CHIP than others with large cell lymphoma. For the context of this, we won't necessarily get into those details, and this is something you can discuss with your clinician in the visit. But because of some of the issues we have with segregating large cell lymphoma into different subtypes, again, some people have suggested we just use polar R-CHIP for all patients because there is really not an increased toxicity. And while it may not benefit everybody, it does benefit a subset. And since we don't necessarily have a great way of testing for these different subsets, again, it's better to treat all than necessarily undertreat some with R-CHOP, which again appears to be inferior in a subset of patients with large cell lymphoma. If you go to the next slide, it will demonstrate graphically what the progression-free survival benefit was. So again, as you see, you can put, if you were to blow that up, you can probably fit 2 fingers between the 2 curves, between the green curve and the blue curve, the green curve being polar R-CHIP, the blue curve being R-CHOP. Again, suggesting that, again, these patients had a longer or greater benefit with keeping the disease in remission than those who were given R-CHOP. Now, as you see below to the right, there is not a survival benefit as of yet, as survival between the 2 arms remains the same. And part of this we'll discuss later is related to improvements in some of the treatments we have in the 2nd and 3rd line setting in patients with large cell lymphoma. Next slide, please. So as we summarize just the recent NCCN updates, so our National Comprehensive Cancer Center Network update has placed a Polar R-CHP as a Category 1 recommendation. It does not say this should be used in place of R-CHOP, but can be used in place of R-CHOP in patients. So again, it is up to your physician to make sort of the distinction whether they want to use Polar R-CHP or R-CHOP. But again, as I mentioned before, some people have advocated for Polar R-CHP for all the patients, given the lack of significant safety benefit between that and R-CHOP. So again, no increased toxicity with this new medication. And overall, knowing that the category of patients who does benefit greatly from Polar R-CHP, today we do not necessarily have a great or sort of solid way of distinguishing between these two patient groups. And so in some situations, again, given this treatment regimen in the frontline setting may be best for all, as again, you do not undertreat a subset of patients, and even though you may slightly give a different subset who may not necessarily significantly benefit from Polar R-CHP. Again, no overall survival benefit, and as I mentioned, that subset of patient is really called activated B cell subtype. We have no accurate way of distinguishing between activated B cell subtype and germinal center within our standard day-to-day practice. And again, for the most part, the only test we can do has about a 20% error rate, which is why some people suggest giving Polar R-CHP to every patient with advanced stage large cell lymphoma. Next slide. So next, we'll turn our attention to the relapse refractory setting. So for the most part, in relapse refractory large cell lymphoma, I would say the biggest change has been the advent of CAR-T, which is chimeric antigen receptor T-cell therapy. This has fundamentally changed how we've approached patients who relapse in the second line setting, meaning you get treatment in the front line, whether it's R-CHOP or Polar R-CHP, and your cancer comes back. Again, CAR-T has fundamentally changed how we approach these patients. The downside to CAR-T, obviously, is it's limited to certain centers. So again, you cannot go to your everyday local oncology office and receive CAR-T. There are only certain centers within the United States that are approved to give CAR-T because of some of the complications and the fundamental sort of steps that are needed to construct this CAR-T product and have these cells returned back. Again, we'll discuss that in some detail. And also we'll discuss bispecific antibodies, which is an off-the-shelf way of still utilizing your own T cells to fight off your cancer. But again, because of some of the risk factors, this has been limited in how it is to reached out to some of the community sites. Even though you do not need sort of a formal sort of accreditation or restriction to use bispecifics, the restriction has mainly been from the physicians themselves who may be uncomfortable with some of the side effects that come with bispecific antibodies. Next slide, please. So the biggest change was historically when a patient was in second line setting with large cell lymphoma, these patients were traditionally treated with very high doses of chemotherapy and then had a consolidation, which means a reflexive second therapy with what we call an autologous stem cell transplantation. And autologous stem cell transplant is really just more chemotherapy, and we use a patient's own stem cells to sort of rescue their body from the toxicity of the chemotherapy. So an easy analogy of looking at this is if you look at your body as an island, and unfortunately you have some bad characters on the island, which are the cancer. This is akin to basically shuttling off some good people, which you know don't involve the cancer. You put them to safety. You basically bomb the island with the chemotherapy, which is what we use in the preparative for the transplant. And then you shuttle the people back to repopulate the island, is what we do with your own stem cells to recover your body from the toxicity of chemo. What the study showed, which we'll go through in the next couple of slides, is that using CAR-T, which is basically collecting your own T cells, manufacturing and sort of adjusting these T cells to better recognize your cancer and giving them back, was more effective in most second-line patients than, again, the auto transplant. And again, that has fundamentally pushed the CAR-T cell therapy into the forefront as a standard of care in second-line therapy, especially for patients who have early relapse of their cancer, meaning your cancer does not respond to your initial treatment or relapses within the first 12 months of therapy. After that situation, it is really up for discretion. There is some data that has shown that auto transplant is still beneficial in some patients with late relapses, even compared to CAR-T, even though we fundamentally do not have a study that has truly evaluated this sort of concept. I don't necessarily know if that'll ever happen because, again, some of the concern with CAR-T is really related to the cost of the procedure and the limitations with CAR-T compared to some of the other treatments that can be offered in other offices. Again, bispecific antibodies are also thought to potentially have some curative potential in this patient population because, again, they are functioning the very same way as CAR-T without the manufacturing process. even though the studies are still a bit immature to sort of demonstrate any survival benefit from these agents. And so we will have to wait for the next couple of years to get some sort of determination whether bispecifics can be curative. Next slide. So this cartoon just basically gives you an overview of what a CAR T cell therapy is and how it's made. For the most part, we are taking a receptor on your T cell and again modifying it so it is more sort of receptive to recognizing the cancer cell. This is done outside of the body after these T cells are collected. This process of sort of manufacturing a T cell takes about 2 to 3 weeks. Then the T cells are returned to the patient and then re-administered. The whole process of CAR T probably takes about 2 months because again, you have insurance approval. There are certain tests you have to complete. Then these T cells are collected, shipped off, and then they have to be returned. And then the T cells have to be given back to you again for the treatment to work. So again, it's not necessarily a process where you can walk into the office and get CAR T cells therapy the next day. It is something that sometimes we have to give other treatments to keep the cancer under control until these CAR T cells are sort of ready to be returned to the patient. Next slide, please. So there are 3 CAR T products approved in at least the third-line setting. There are 2 approved in the second-line setting. And so the 2 that are approved in the second-line setting are Axicell, which is the Kite Pharma product, and then Lysocell, which is now owned by BMS. The Novartis product, Tycel, is approved in the third-line setting. All 3 are available in the third line. Again, Axicell, Lysocell are available only in the second-line setting. And as you can see, the real difference being if you look at the one to the left and the 2 to the right, you'll see that the engine is a little bit different. So the 2 on the right have what we call a 41BB, which I will say is more close to a Corvette. And the one to the left has a CD28, which is like a Lamborghini. So when these cells are re-administered to the body, that engine determines how fast these cells grow and replicate. Again, you have the slower ones to the right and the more rapid ones to the left, which in turn also sort of relates to some of the side effects we see. You see more incidence of some of the side effects with the one to the left than you do with the 2 to the right, based on the engine that's being used. Also, if you look just below the green at the top, you'll see that the hinge is CD28 for the Kite Pharma product and the BMS. So the one to the far left, the one to the far right have the CD28 hinge. The one in the middle has a different hinge than those other 2. Again, some people speculate that some of the efficacy differences we may possibly see between these drugs are related to the differences in the hinge. Again, this has not been sort of determined in a formal head-to-head study. So this is, again, all speculation. Next slide, please. So again, if we want to look at sort of these drugs, so again, in the second-line setting, some of the studies that were used, again, we have 2 approved products, 1 product that was not approved. Again, the one in the top line, Axicell, which is a little bit more aggressive one of the 3, has shown an overall survival benefit. But the difference between this and the other 2 is that when patients were enrolled on that trial, they were not allowed to cross over. So if they failed the standard of care, which is an auto transplant, they could not automatically just necessarily receive the CAR T product. They had to receive the CAR T product as a standard of care. With the one at the bottom, Lysocell, those patients were allowed to cross over. So if they failed to have a good outcome with the auto transplant, these patients were allowed to cross over and get Lysocell on the clinical trials, which allowed them to get it much quicker, which may explain why we don't have a survival benefit in that study as of right now. Again, the choice of which one of these to use, Axicell and Lysocell, may be based on patient's age and fitness. Again, Axicell is associated with more toxicity than Lysocell. So if you're a younger patient, again, if we suspect that you can tolerate Axicell and some of the complications, that may be the one you'll receive. Whereas with Lysocell, again, if you're an older patient with more sort of health conditions and issues, again, that may be the best choice for you in that situation. And again, also we have to take into consideration the manufacturing process. Again, if we talk about when the physician thinks about when you should get CAR T when you actually receive it, again, some people refer to brain to vein time, that can impact your choice of which CAR T agent, because again, sometimes you may not have that much time for the CAR T to be manufactured before the patient actually needs that treatment. Again, some of the questions we still need to answer and some fundamental things that will be developed in the next couple of years. But the biggest issue with CAR T at this point is access. We have to be able to get access of CAR T to more patients because, again, it is limited to certain centers. Again, depending on where you are in the country. So East Coast, some areas in the Midwest, and then obviously West Coast, especially in Southern California, there are numerous CAR T centers. But if you're in other areas, there are no CAR T centers anywhere. So if you're in Idaho, Wyoming, or in some other places in the country, in the Great Plains, there's limited access to CAR T, and some areas in the South also have very limited access to CAR T. Next slide, please. So next we'll talk about bispecific antibodies. So for the most part, we'll focus on 4. There's mosunetuzumab, glofitamab, odronextamab, and epcoritamab. All 3 of the 4 are approved agents. So the mosunetuzumab and glofitamab are approved. Mosunetuzumab for follicular lymphoma, glofitamab for diffuse large B-cell lymphoma. Epcoritamab is approved for both follicular lymphoma and large cell lymphoma in this patient population. Next slide, please. Next slide. So glofitamab, as I mentioned, is approved for large cell lymphoma. So these drugs are a bit different from CAR T specifically, as these are off the shelf. So basically, in a perfect world, you can walk into a physician's office and get treated with this medication the next day or even during that week as soon as you get insurance approval. These medications have to be given in what we call step-up dosing. So basically, you get a very small dose, you get an intermediate dose, and then you get the full dose. With glofitamab, you do get a pre-dose with a medication called obinutuzumab. So this is given, say, cycle 1, day 1. The following week, you would then come in to get glofitamab at 2.5 milligrams, which is the baby dose. The following week, you come in and get it at 10 milligrams, which is an intermediate dose. And then the following week, you will get the full dose, 30 milligrams. Thereafter, you will continue to get glofitamab every 3 weeks for a total of 12 treatment cycles, then the treatment stops. Again, so remember, this is a finite treatment period. So for the most, you get 12 cycles of therapy, and then the treatment stops and you are then observed. Next slide, please. So again, if we look at the original response rate, so this has an overall response rate that's 51.6% and a complete response rate of 40%. This is less than what we see with patients with CAR T, but the also thing to consider, this was studied in patients in the 3rd line. So you failed 1 treatment, you failed a 2nd treatment, then you were able to get this treatment. And some of the patients who enrolled in this trial had already failed CAR T. So again, it's a very different patient population from what we saw with some of the original studies that allowed CAR T to move into the 2nd line setting. And if you can think about as we move forward, the biggest thing we'll need to look at with these studies is if these patients that are off treatment, if their cancer is not coming back, this is suggesting that we are curing these patients with glofitamab, which I mentioned before, we still need more time before we can make that determination. Next slide, please. So this curve here just shows that patients who have obtained a complete response, as you can see there, the plateau to this curve suggesting that these patients are remaining in remission. Again, the median follow-up is still short, so we just do not have enough time to say for sure these patients are cured, but this is very encouraging early data suggesting that this treatment modality can be curative as well in patients with large cell lymphoma. Next slide, please. So epcoritamab is the other bispecific approved in patients with large cell lymphoma. The biggest difference between epcoritamab and glofitamab is that epcoritamab is a subcutaneous treatment, whereas glofitamab is given through the IV. Also, step-up dosing is different. So the dosages that we use are different. So glofitamab starts at 0.016. The following week is 0.8, and then the following week is 48 milligrams. And as you can see, it is given every week for cycles 1 through 3, every other week for cycles 4 through 9, and then it's continued once a month indefinitely. So where glofitamab was a treatment that stopped after 12 cycles, epcoritamab goes until patient's intolerance or we stop for another reason. Both treatment modalities have very similar overall response rate and efficacy rates. We are still trying to determine if there's any long-term benefit to continue epcoritamab indefinitely versus glofitamab, which again is a finite treatment, meaning you stop. Next slide, please. So as you can see, overall response rate, complete response rate, very similar to what we saw with glofitamab, even in some high-risk patient populations and even in patients that were quite older versus even the younger patients, and even irrespective of patients whether they had or had not received CAR T-cell therapy. Next slide, please. Again, this curve also demonstrates some durability of response with patients who obtain a complete remission, very similar to what we saw with glofitamab. But again, the big caveat is patients with glofitamab will have time off treatment, whereas those with epcoritamab will continue treatment indefinitely until intolerance. Next slide, please. So the main side effects of both bispecific and CAR T is what we call cytokine release syndrome, or CRS. And then other one is a neurological complication called immune effector cell-associated neurological syndrome, or ICANS. So for the biggest part, CRS constitutes fever, low blood pressure, or shortness of breath. This will generally happen very quickly. So with bispecific antibodies, we will typically see it within the first couple of days with epcoritamab, or within the first couple of hours after glofitamab. And it generally resolves within 24 hours. With CAR T-cell therapy, it will take generally a couple of days. You'll see an earlier onset with axi-cell versus lyso-cell or T-cell, but just CRS with CAR T sometimes will have a longer time to resolution, so days versus hours typically with the bispecifics. And remember, with CAR T cell therapy, you will be inpatient for about 1 to 2 weeks for monitoring for some of these complications. Whereas with the bispecific antibodies, if you are admitted to the hospital, it's just a 24-hour observation. ICANS, which are neurological complications, which can be sleepiness, confusion, difficulty with reading, writing, etc. So these are a later side effect with CAR T cell therapy. They are very infrequent or bispecific, so this is mainly just a CAR T cell therapy side effect. Again, this will generally occur several days after receipt of CAR T cell therapy and can be seen up until a week or so after you receive CAR T cell therapy. This is a side effect that is still reversible, but does sometimes take some time to reverse versus CRS, which is generally the quickest of the two to resolve itself. CRS can typically be resolved and fixed with steroids, a medication we call tocilizumab, which is an IL-6 inhibitor, which we'll typically give you in the hospital. ICANS sometimes is resolved with steroids. We will sometimes have to give other medications if not resolved with steroids. Again, as I mentioned before, symptoms of both are more severe with CAR T than what we typically see with bispecifics. Next slide, please. So just to summarize, R-CHOP is still an option for frontline therapy, but again, some people will advocate that polar R-CHP should be our new standard of care for all patients. Again, we'll wait further follow-up of the POLARIX study, which sort of supported polar R-CHP in this frontline setting. With relapse refractory disease, again, CAR T remains the mainstay for second line and even third line therapy for most patients if you can get to a CAR T cell center. Bispecifics may sort of push CAR T cells to the side in some situations. And because of their combinability, we may actually see bispecifics earlier before CAR T cell therapy, because a lot of these are being explored in the frontline setting. But as of now, they are drugs that we can use with patients in the third line and beyond setting. So again, if they fail frontline therapy, fail second line therapy, and they can't get bispecific antibodies, this can be given in community centers, whereas CAR T cell therapy cannot. Again, for the most part, your main side effects are cytokine release syndrome. This can be managed in the clinic. It just does take some sort of comfortability for the physician to get comfortable with identifying and treating these side effects. I do expect that most community centers will start using bispecifics in the next several years. And so that will be something that, again, you will not have to travel to an academic center or some of these bigger community centers to get treatment with in the future. With that, I will conclude and open it up for questions.
Thank you, Dr. Phillips. Let me get back to my screen real quick. Thank you for that informative presentation. It's now time for the discussion part of today's webinar. If you have any questions about DLBCL or anything Dr. Phillips spoke on today, now is your chance to ask questions. This time is specifically set aside for our community members to have a chance to talk to our incredible presenters, so please feel free to ask any questions. As a reminder, you can ask a question, or you can make a comment by typing in the chat box, or by raising your hand if you would like to ask a question verbally. If raising your hand once you are called on, you can unmute yourself and ask your question. It looks like we have a couple of questions. Okay, what side effects come from R-CHOP treatment?
Sure. So, and sorry, there's just a lot to cover in a short time. So I'll start just in how we sort of see the drug. So rituximab generally will have an infusion reaction. So this is basically like an allergic reaction since it is an antibody. So patients can sometimes get some itchiness, rash, hives. In some rare situations, patients will complain of some difficulty breathing, things of that nature. Rituximab side effects will happen in the infusion center, so you will be in the doctor's office. We give you medications ahead of time, generally Tylenol, Benadryl, sometimes steroids to mitigate these side effects. If any issues happen during the infusion, rituximab is paused. Thereafter, we will give you additional medications, generally additional Benadryl, sometimes Pepcid, which is a histamine blocker. We'll sometimes give singular and other medications that block the immune system, and then we will slowly increase the infusion back up. After the first infusion of rituximab, most patients will no longer have any issues with that medication. And if things continue to go okay, the infusion will go from around 6 to 8 hours down to 2 hours moving forward, sometimes an hour and a half. Cytoxin is a chemotherapy drug, so it can cause nausea, vomiting, hair loss. It will impact your blood count and increase your risk of infections. Specifically, we worry about bacterial infections because a particular type of your blood cell called neutrophils will become low. Based on the patient's age, we will sometimes have to give a shot to stimulate your neutrophils to help circumvent some of the decrease that happens with Cytoxin and other chemotherapy drugs. Adriamycin or hydroxydoxorubicin, again, is another chemotherapy drug. It can cause some of the same side effects. So again, nausea, vomiting, hair loss, constipation, low blood counts, which can lead to increased infection. All of these can sometimes also cause taste changes and sort of decrease in appetite. Hydroxydoxorubicin has a very particular side effect, is it can sometimes weaken the left part of the heart. We're specifically talking about your left ventricle, which is the part of the heart that pumps blood out to the rest of the body. So you do have to get a test called an echocardiogram before we start RCHOP. It is an ultrasound of the heart. As long as your ejection fraction is normal, you can proceed ahead with RCHOP. With Cytoxin and with the hydroxydoxorubicin, most patients will lose their hair. So we do also encourage people who are very conscious about hair loss to start looking at wigs before we start therapy. Vincristine and polatuzumab's main side effect is neuropathy, meaning irritation of the nerves in the hands and the feet. It can be tingling, numbness, or sometimes loss of fine motor function, meaning patients will have issues with buttons, zippers, and jars. Generally, if this happens, we will have to make dose reductions or hold the medication. I generally counsel patients that if this happens with the second or third cycle, it's usually the cycle previously that caused the damage, so it may get a little bit worse before it gets better. For the most part, neuropathy will resolve as long as we intervene and stop the medication soon enough. The last medication is prednisone, which is a steroid. So prednisone side effects are generally, it can increase energy, it can increase your appetite. It also can cause some difficulty sleeping. So we generally advise patients to take steroids in the morning as early as possible, because if you take it later in the day, you may not be able to sleep. And in some patients, it can increase agitation, so they can become a bit more irritable. But for the most part, steroids are beneficial, and that can also help sometimes with nausea. As a whole, the biggest things that we worry about with most patients are infections, especially if they're older, constipation, because all of these medications can slow gut transit. So a good bowel regimen is important. And again, fatigue is common with all these medications. But for fatigue, the general fix is really to stay active. I know that sounds a bit more counterintuitive, as generally if you're tired, people tell you to rest. But with chemotherapy-induced fatigue, you should try to stay as active as possible, because that will help your body sort of overcome the fatigue from the chemotherapy.
Perfect. Thank you so much. I have a couple of pre-submitted questions. One of them was, who is eligible for a stem cell transplant?
So for the most part, stem cell transplantation is anyone 70 and younger. Some centers will still transplant patients 75 and younger, as long as they have adequate heart function, lung function, and there's no other abnormalities noted in their bone marrow. These are important because we typically, when we give the stem cell transplant, remember, it's really mostly just chemo. We give a regimen called BEAM, which is BEAM. So B stands for a medication called BCNU or carmustine. E is a topicide. A is a medication called Aracy or cytarabine, and M is melphalan. Those medications, as I mentioned before, will wipe out the marrow, which means that your blood counts, the thing that sustain us, will be severely limited. And most patients will not recover blood counts unless we give their stem cells back that have not been exposed to the chemotherapy, which is where the transplant part comes in at. But carmustine can irritate the lungs. All of the whole transplant drugs together can cause some issues with the heart. And so that's why they have to have good cardiac and pulmonary function before we proceed ahead. And also, we don't necessarily, if the marrow has some abnormalities, because we don't want to induce like secondary leukemia or MDS. If a patient has an abnormal marrow, that would exclude them also from receiving a stem cell transplant. But the easiest answer is just age. If you're 70 and younger, you're generally guaranteed to be approved for a transplant unless there's some outstanding reason. Between 70 and 75, there's always some concern. And so you may be evaluated a bit more stringently. And if there's any concern, they will probably recommend you not go through a transplant.
Thank you. Another question I got was, what does it mean to have double hit DLBCL? Does that make me higher risk?
Yeah. So again, large cell lymphoma has a lot, so I didn't want to get too technical. So the easiest way to look at a double hit is that your cancer has acquired a component that allows it to become more immortalized than a cancer cell already is, and also a portion that allows it to grow faster. So they basically picked up a mutation that allows for amplification of c-Myc, which is basically like it just turbocharges the cancer, and then BCL2, which allows the cancer to sort of resist death. Um, what we know with double hit lymphomas, they do not respond very well for the most part to R-CHOP. Even in a Polaric study, they did not respond very well to polar R-CHP. We have not necessarily had a prospective study that has identified an appropriate treatment regimen for these patients. We basically relied on retrospective data, meaning we've looked at patients' outcomes and how they were treated with certain chemotherapy regimens and went back and sort of said that patients seem to respond well from that. So that's what we're going to use. And so for patients with double hit, we would treat them with a regimen called R dose adjusted EPOC. It is very much alphabet soup. Everything in our dose adjusted EPOC is in R-CHOP. The only thing we add is a medication called etoposide. So the R is still rituximab. The DA is just a dose adjustment that we do. E is etoposide, P is prednisone, O is vincristine, C is Cytoxan, and H is hydroxydoxorubicin. So again, all the same medications in R-CHOP plus etoposide. The real difference is that instead of giving this all in one day, most of these medications are infused over 4 days. And on the fifth day, we just give Cytoxan, and that's repeated again every 21 cycles. Based on how severely your blood counts are impacted, with your next cycle of therapy, the dose of the medications, it may be increased 20%, kept the same, or decreased 20%. That is the major sort of dose adjustment part. And that is really the major differences between that and an R-CHOP. But dose adjusted EPOC is generally our standard approach for patients with double hit, as these patients typically have worse outcomes if you treat them with R-CHOP. The other thing with a double hit patient is, unfortunately, these patients do not seem to respond very well to an auto transplant. And so if they fail frontline therapy, we very seldom, if ever, try to get them to an auto transplant. And these patients, generally, if we can, we'll try to get them to CAR T-cell therapy.
Okay. Thank you so much. That leads me to another question that was asked, and that is, how accessible is CAR T-cell therapy to patients?
Yeah, unfortunately, it's really geographical. If you live in Boston or New York, you have a lot of areas where you can access CAR T. So that I guess you can extend that to Pennsylvania and New Jersey. There are probably about 30 CAR T centers in that little small area. As we move east, the next CAR T center, I believe, is in Pittsburgh. Then you have Cleveland. Then you're looking at Michigan. Um, there's one in Indianapolis. There's one in Chicago. Actually, there's a couple in Chicago. There's one in Milwaukee. But as you move further west, you get less and less until you get into the Southern California area. There's a CAR T center in Houston. There's one in Alabama. And there's one in Georgia. But if you live in Mississippi, there's no place to get CAR T. And even in Florida, there's one in Miami, and I think there's one up near Tallahassee where you can get CAR T cell therapy. But for the most part, the rest of that state, there may be one in Orlando, is without access to CAR T in the immediate area. So again, if you are in certain parts of the country, you have your pick of the litter. If you're in other parts of the country, you may not have a CAR T center within 500 to 1,000 miles of where you live at. And it will really require you to travel and relocate with another person, because you can't get CAR T by yourself. If the center can't provide a caregiver, then somebody has to travel with you. And that means that you and another person will have to relocate to another state, another city for at least a month.
Oh, wow. I didn't know that. Thank you for sharing. A question that I wanted to ask was, what advances do you predict in DLBCL in the next few years for treatment or whichever?
Yeah, so I think so we'll do two things. So one is treatment wise, I really think that bispecific antibodies, as I mentioned, will move into the frontline setting. So we'll likely have a new standard of care. Because we will be giving them with chemotherapy, that may mitigate some of the concerns and risks of cytokine release syndrome, which will encourage more community physicians to use these bispecific antibodies and increase patient access. So again, you can go to your local oncology office and hopefully get a bispecific, but not necessarily have them have to worry about dealing with some of the side effects, which some of them don't want to deal with right now. Sort of diagnostically wise, we're still trying to hopefully find a better sort of mousetrap. So we've used PET scans quite a bit to evaluate for response and sort of determine if patients are in remission or not, meaning that we can't find the cancer. Right now, we're working on testing called ctDNA, which looks for the DNA of the cancer within the patient's blood. The thought is that this will be a more sort of sensitive test, basically will allow us to find more patients who may have cancer still present that may not show up on a PET scan, or give us a better idea of patients that will long-term have very good outcomes versus those who won't. So ctDNA will hopefully be a better mousetrap for us to better give an idea for patients once they finish therapy, whether they are truly in remission and hopefully cured from the cancer, or those who we suspect may be in remission but really aren't. And we need to do more treatment before the cancer really comes back and becomes a difficult thing to treat.
Perfect. Thank you so much. With that, I'll probably move on to the closing portion of this. And before we go, I wanted to highlight Track My Disease feature in HealthTree Care Hub. Once you've connected your medical records, the Track My Disease feature provides you with the ability to gain one-of-a-kind access to your health information, encompassing lab results, genetic profiles, and treatment histories, offering you invaluable insights to your own medical journey. On the screen, I have a link to sign up for HealthTree Care Hub along with the email address of our amazing patient navigators who are available to help you create an account and connect your records. I will also include information about how to enroll in HealthTree Care Hub in our follow-up email, so be on the lookout for that. And then here are some upcoming events I wanted to mention quickly. On Thursday, September 5th, we'll publish a podcast about research advancements for HIV-associated DLBCL. On September 18th, we'll have a live webinar about tumor lysis syndrome. And on September 30th, we'll have a blood cancer event for Blood Cancer Awareness Month about innovations in blood cancer. The link to sign up for any of those events is found at the bottom of this slide and will be sent out in our follow-up email. As a reminder, we would appreciate you taking our 2 to 3 minute brief survey about your experience today. Zoom will prompt you to take it as soon as you leave this event. You can submit topic ideas through the survey as well. As always, I would like to thank our sponsors for whom we could not have done this event without. That's Regeneron and Bristol Myers Squibb. And finally, I just wanted to say thank you all for helping us build our DLBCL community. I've added my email to this slide. Please don't hesitate to reach out if you have any questions about HealthTree or any of our programs. I appreciate everyone, and I hope you have a great rest of your day. And I hope to see you at another webinar soon. Thank you, Dr. Phillips.
Thank you. And thanks everyone for showing up today.
Thank you. You can leave. I'm just trying to end the.
Okay. All right. Thank you. Take care.
Thank you.